Hey everyone, welcome to the knee kinesiology lecture. If you can believe it, we are already halfway through the second unit. We only have a few more lectures left before we have the unit test. This is a condensed unit, but still a lot of content, right? So let me know if you have questions, but we're almost through, we're halfway through this unit, which means we're getting halfway through the semester, which means you're almost done and you've done so well so far. So let's go ahead and get started on this lecture. And every time we have a kinesiology lecture, we can review some anatomy just to help us give a context. So I'm not going to go into a lot of, like I did with the hip, I'm not going to go a lot of information that we've already talked about, but try to point out things that are helpful. So as we look at the knee, we have basically three joints that are happening here. We have the medial and lateral compartments of the tibiofemoral joints, and we have the patellofemoral joint. The tibiofemoral joint obviously acts as one. It's bicondylar, it's an synovial joint, has medial and lateral condyles that kind of work together to flex and extend the knee. And then we have the patellar joint that kind of slides on top of the femur, and it helps act as a moment arm extender for the body, and we'll look at that a little bit. So, soft tissue, like muscles, tendon, ligaments, provide most of the stability for the joint. There's not a lot of like in the hip, there's this really deep socket for the hip, for the hip to kind of go into, like kind of fits in there, and it takes a lot of pressure to get out. With the knee, you're almost having these two slightly flat concave and convex surfaces on top of each other. So a lot of the support that keeps them together is in the soft tissue. Not a lot of bony stability. There is a very strong functional relationship with the knee between the hip and the ankle. And usually movement at the knee will affect the hip and the ankle, or vice versa. So, and that is because a lot of the muscles that cross over the knee cross over the hip as well. And there's some muscles that cross the knee that affect the knee will also affect the ankle. So we'll talk a little bit more about that as we go. As we see the closed kinematic chain, the knee in a closed chain movement, the knee works with the hip and ankle to support the body. In open chain, the knee provides some mobility for the foot placement, and we'll look at a little bit at that as well. So if the foot is free, it's moving around, it's moving, flexing, extending. If it's not, then it's helping support the body and help keep the body going up and down. So the patellofemoral joint would be this right here. It is the intersection between the patella and the femoral. It is synovial as well. Has synovial membrane is a seismoid bone, so it's unusually shaped, meant to accomplish the purpose that it's for. It's exactly shaped for the place that it's in, and it's not the same on both sides. So there's asymmetry, and that asymmetry follows the pattern of the femur. As you kind of see here in this picture, there's just some slight differences between the angle of the patella, and that follows the angle of the femur, so it can slide up and down easily. The medial femoral condyle is larger than the lateral, has a little bit more muscle attachments there, so it probably needs to be a little bit bigger. The medial tibial condyle is slightly concave, and the lateral is more flat. So there's some differences between the two. The lateral femoral facet of the patella has a steeper angle than the medial facet. So that kind of like we looked at there. So that steeper angle here, and that should be patella. Although there's one T and two A's. Anyways, okay, so kind of looking at some of the angles of the knee, like we did with the hip. So just like in the hip, there are some abnormal or angles that can happen that can create some functional deficits. So normally, the shaft of the femur angles medially due to a normal angle of inclination, and so we have a normal angle about 170 to 175. And that is called genu valgum. It's not exactly straight, but we can have excessive genu valgum where that angle becomes less than 170 degrees, and we see that as knock knee, and see that angle has decreased from 170 to 175 to 165, and that is excessive genu valgum or knock knee. And we also have genu varum, which is where the lateral angle is greater than 180, and we often will call that bow-leggedness. And this can cause strain on ligaments, as you might guess. And we'll kind of look at those ligaments too, but as you might guess, these angles, the ligaments here on the lateral ligament and the medial ligaments here, because they are angled in and pushed against more, they're going to be on stretch all the time, and then they become more likely to be injured because they are stretched to further than they should be. And as we know, when something's stretched too far, that has more likelihood of being injured. As we can see here, sometimes the hip can cause these problems. So as we remember, we talked back about the hip. We have coxavera. Well, guess coxavera at the hip, where there is this increased angle there, can cause the femur to be angled a little bit more medially, which then causes knock-knee, causes the angle of the knee to have some valgum and to be knock-kneed. So here we go. Coxavera at the hip often results in excessive genu valgum at the knee. Coxavalga at the hip may cause genu varum at the knee. So if we have the opposite happening, if we have this more angle here, it pushes this out, which means we have a little bit more in for whenever we'd be more have that genu varum, the bowleginess, if that angle has decreased enough on the hip. So we have a lot of dysfunctional relationship. So people can be born with coxavera, and then it can lead later to to genu valgum, or it could be that we have knock-kneed. We were born with knock-kneed, and it causes the hip to be disformed. Sometimes, like my grandpa was a rancher, he rode horses, and he became knock-kneed because he rode the horses all day long, every day, and his body started to kind of adapt to that position, and so he was bow-legged when he became older because of the long-term stretching of those tendons, which kind of led to the body to kind of form to that position. So as I talked about those ligaments, so we have medial and lateral ligaments that, as you might guess, follow the medial and lateral side of the knee. They provide stability in the frontal plane, so they're not going to let you have too much of that lateral, like flexion, things like that. And the medial collateral ligament is attached to the medial meniscus. So we can see that here, the medial meniscus here, it's going to have that attachment directly to it there. So you can see that medial meniscus and the medial collateral ligament. You'll hear a lot of times about this MCL injury, and that you'll see the medial collateral. It's because of its position and the likelihood of being hit kind of from the side and getting pushed inwardly. So if someone came in and hit you from this way and hit that way, it has a more likelihood of that happening than maybe someone coming from this way between your legs and pushing it out, right? So you have a little bit more vulnerable to injury than the LCL, which is here. So lateral collateral ligament is going to go there. Its proximal attachments are posterior to the medial-lateral axis, and we'll look at that in a second. And then it's relatively tight during extension, which helps keep the knee stable when it's fully extended, and relatively slack during flexion. And you can see that here. So here we have the ligaments. They have the anterior cruciate ligament, the medial cruciate ligament, the posterior medial capsule, and then we have the oblique popliteal ligament. So these are the different ligaments that are attaching on the femur to the tibia. And you can see that, let's, for instance, look at the MCL here, to where we have here, its attachment is posterior to the axis of rotation. So when we flex, that attachment gets really close to the attachment of the tibia, and so it becomes loose. When it gets pushed forward in full extension, it goes farther away and it becomes taut. So this is where we talked about here. So relatively tight during extension and slack during flexion. This is why it's because of those ligaments are attached posterior to the axis of rotation, which we need to have that full flexion. Otherwise, if our attachment was up here, right, then you'd have this really tight ligaments in flexion, and would provide lots of stability in flexion, which we really don't need. We need stability when we're standing up tall and we have our legs fully extended, so we have more stability at that knee when we are fully extended, usually putting weight through the leg as we stand, as we walk, and do those things. So the menisci, not going to be super important for maybe the test, but some things to know. They're fibrocartilagic discs, basically. They're like little cushions that lie inside of the joint. which help to deepen the flat surface. So because it's such a flat surface of the knee, there's not a lot of support there. This helps deepen it a little bit, give you some kind of cushion, and helps to keep the bones together. It also helps guide the movement of the knee as it goes through full extension, back to flexion, and vice versa. So a lot of the ligaments attach to these menisci, and so they help move. They can actually move with the movement as it goes around. These little discs can have a little bit of play. It helps to redistributes the forces, just like the other kind of discs do in the back, and at the hip has that as well. The medial is a little bit oval shaped. Is an oval more C-shaped, and the lateral is going to be more O-shaped and circular. So you kind of see that here's that medial, which is going to be that C, and the lateral, which is going to be more this O-shaped, circular shape. Very low blood supply to these menisci, which why when you injure them, they're more likely to be slow to heal, because we need blood to be able to heal something in the body. So oftentimes will have to be just replaced. The meniscus are often replaced because they just can't be healed. And so a lot of times you'll hear these meniscal surgeries where they give a meniscal replacement, and that is why, because it just doesn't have really good blood supply, which is good because we need lots of cushion, but if it injures, then you're kind of out of luck. So then we also have the medial collateral and lateral collateral that are happening here. We also have anterior and posterior cruciate ligaments, which are going to kind of run more medially and go from anterior to posterior and posterior to anterior. They're named for their tibial attachment. So you can see here is the anterior one. It's attached anteriorly on the tibial and goes back. And then we have the posterior, which is attached posteriorly on the tibia and then goes forward. So they kind of crisscross each other here. Crisscross each other as they change directions. And they are meant there to help resist extremes in all movements. And so when you extend, you're going to have the anterior cruciate tighten, and when you flex, you're going to have the posterior cruciate tighten. And so they're going to give you this proprioception as well, that lets you know kind of where your knee is in space. If those are injured and cut, you may not be able to know where they are without looking at your knee as well. It kind of gives you this idea. So proprioception is this idea that you can know where your body is in space without having to see it. So I can close my eyes and I can say, lift my right hand to 90 degrees, and I can get there pretty close to where I want to be without having to look at it. If I have no proprioception, I wouldn't know where my body was whenever I was moving my arm. I would move my arm but not really know what was happening. We have some people that have injuries to either ligaments or the brain that processes proprioception is injured, and you go close your eyes and they won't be able to function anymore. Anyway, so that's what these cruciate ligaments do for the knee, and they help to provide that proprioception input. Also provides stability in the sagittal plane, limiting anterior and posterior shear forces. So keeping them together, so the bones aren't moving too far away from each other. It's kind of keeping everything in place, along with the medial and lateral ligaments, keeping stability. So they're really important for the knee function, since there's, like I said before, there's not a lot of bony help. The ligaments are really what help guide and support the movement of the knee. So here we see active knee extension that's happening. We have the quadriceps contract, right? And the quadriceps kind of come over the top and attach that patella, come over the top, and the patellar tendon is going to attach onto the tibia, and it's going to pull that tibia forward, slide it up, so it goes and it makes the full extension over the femur's condyles. So that's kind of what we do with active extension. We have this also idea, there's this ACL test, this anterior draw test. You can test if an ACL is injured. If it is, normally when you do this, you have the spasm that happens. When you have someone laying down, you bring their tibia forward, you tighten the ACL, and you'll have a spasm of the hamstrings. If that ACL is torn and there's no reaction there, then the hamstrings will not spasm. So not something you're going to be doing very much as an OT. So this is more FYI for what you need to know. There's a bursa for the knee and synovial fluid as well. So the bursa is in all joints, help to reduce friction, help keep the movement easy and help movement happen. And then the swimming fluid, like as you know, it's going to be inside the capsule, helps to lubricate the movement, keep all the movement happening well. And then because there's movement, the fluid can move forward or backward depending on where the knee is. And so in extension, that's forced anteriorly, and in flexion, it's forced posteriorly. Kind of like that idea in the vertebrae, as you like squish one side, it gets bigger, and like this, so you have this like flow of fluid as you're moving. Obviously, it happens really fast, and so, but it is there. So, and then semi-flex is where it's at least tension, so it's going to be more of the open pack at that point. At semi-flex position, closed pack is going to be obviously full extension. The knee has 2 degrees of freedom. And so we have this flexion extension, which happens in the sagittal plane. It has a medial lateral axis rotation, and it migrates as you go forward. We'll look at that in a second. And then the surface of the femoral condyles is much greater than the surface of the tibial condyles, so you have a roll and a slide that happens in order to keep them in place. Internal rotation happens in the horizontal plane on that longitudinal axis rotation. And we have the external rotation is a lot bigger than the internal rotation. And it's really not a lot that's happening, but you'll have a little bit. And so it's mostly going to happen when we are in closed chain, because a lot of one time when we try to rotate our knee in open chain, it's going to be coming from our hip, not from our knee. But when we're in closed chain and we have our foot to the ground, we can do some twists, and it will give a little tiny bit of internal external rotation. Not a lot. It's going to be very, very minimal. But there is some. So you can kind of see here is open and closed chain movement, tibial and femoral versus femoral and tibial, and kind of how that looks. And here is that migration that we talked about a second ago. So rotation migrates. So here we have that rotation. So here, when we are at full flexion, our axis is here. And then as we extend, our axis kind of goes up a little bit because there's this roll and slide happening, and the bones aren't necessarily fixed to each other. We have a little bit of change of axis as it rotates. So it's influenced a lot by the curve of the condyles. The migrating axis alters the internal moment arm of the muscles that flex and extend the knee, so giving the muscles either help or weakness into certain movements as we change the axis rotation, right? So we can kind of see if we move this line of pull, and as we increase or decrease the internal moment arm from the muscle line of pull, it can help that movement. So, and a lot of this is we use this for measuring the knee angle, right? So when we're measuring the angle of the knee, we would use the axis of rotation and come down this way. I would say that most of the time, if you're in this area, you'll be fine. And so not super important, but just interesting to know. So this is kind of what it looks like, what's happening exactly within the joint. So during tibial and femoral extension, the articular surface of the tibia rolls and slides anteriorly on the femoral condyles. So this is a tibial and femoral extension. So this is whenever it's open chain. And so we have a roll and slide. We have concave moving on convex. And then when we're doing femoral and tibial extension, so this is more of a close chain movement, we are going to have the femoral condyles simultaneously roll anteriorly and slide posteriorly on the articular surface of the tibia. So we're going to have a slide backwards and a roll in this direction. And that keeps this is a concave on a convex surface. It keeps the femur in place on a smaller tibial surface. And so we have to have those things happen in order to keep the bones in the right position for movement. Okay, so now we're going to look at internal and external rotation at the knee. And this can be a little bit confusing, just like the hip can also be a little bit confusing, especially when we look at open and closed chains. And so we're going to take a second and look at these, and then because it's going to play into our next topic, which is the screw home mechanism of the knee. So when we are open chain, this is, so just so we have clarification, this is going to be a right foot and a right foot. So there's not 2 feet next to each other. This is the same side of foot. So this picture can sometimes be confusing because you think that you're looking at the same foot, different feet left and right, but you're actually looking at two right feet. And so when we are externally rotate our right foot, you'll notice that the foot comes this way, and the angle between our midline basically and the foot and the knee, and the foot kind of follows the knee in open chain, right, is going to get bigger. So that is a bigger angle farther away. And in internal rotation, we are going to bring it in, and that angle has gotten smaller. Smaller angle, closer together. So you can see that makes pretty good sense whenever we are looking at the open chain or tibial and femoral rotation. When we look on tibial rotation, it's a little bit more different. So this is when our foot is on the ground and it is kind of in place, not moving anywhere. And now we're going to move our femur, rotate our femur on our fixed tibia. And now we're looking at this angle here versus this angle here. And so we can see this one going from midline right has gotten, if you're going straight, this would be like what maybe neutral would be. This is neutral. Sorry, I'll do it in red. So neutral would be kind of this line down the middle. If you were standing straight without any rotation at all. And so this angle has gotten a lot bigger. So that would be our external rotation. So bigger angle, farther away from midline, or from anatomical position, and this one is smaller and closer together. And so this is going to be our internal rotation. So and what I want to see what's happening here at the femur, right? And so what is happening when we externally rotate our knee? So the knee joint is getting, our knee joint is externally rotating, but what's happening here is that we have an internal rotation of the femur, right? So it's rotating inwardly, right? The femur is rotating inwardly to create an external rotation at the knee, and vice versa. It's rotating externally. The femur is rotating externally to create an internal rotation at the knee. So the bone is externally rotating, but the joint is internally rotating. And so that is where it can be confusing. So, and you'll see as we go forward that this can play some part in the knee locking and screw home mechanism. So the screw home mechanism of the rotation of the knee is this ability that we can lock our knee in full extension. And in order to do that, to lock our knee, we have this screw home external rotation. So it's not the same as axial rotation. So it occurs in the last 30 degrees of extension. It's mechanically linked to the flexion extension kinematics, cannot be performed independently. So you've got to be doing these movements, and it's guided by the shape of the condyles mostly. And so you can kind of see in these lateral medial epicondyles. So you can see the medial one is kind of has more interior, more steep, and the lateral one is here. So as the knee comes to full extension, it's like pushing forward this way. It's pushing forward. It's going to hit the lateral epicondyle first, and it's going to stop it from being able to go any further on that lateral epicondyle. But you have this extra degree of forward motion that you have, that is going to allow the femur to lock in place. So that is the screw home mechanism. So the locking mechanism works for both tibial and femoral and tibial movement. And whether the thigh or the leg is moving segment, the knee joint is externally rotating when approaching full extension. So this is important. The knee joint is externally rotating. That doesn't mean that the femur is externally rotating. It's just that the knee joint itself is externally rotating, which is confusing. But I'm going to show a video that will help kind of visualize what is happening in this movement. So let's go ahead. I'm going to go ahead and pull up that video now. So 1 second. Okay, to kind of reinforce everything that's happening here. So whenever we are externally rotating our knee, our femur is internally rotating to make that happen. And we were internally rotating our knee, our femur is externally rotating to happen in closed chain movements. So when our notes say that external rotation is needed, that external rotation is needed to unlock the knee in both temporal femoral and femoral tibial rotation, that is correct. The movement that causes the joint to externally rotate, though, changes. So external or lateral rotation of the tibia or internal rotation of the femur will help this movement happen, the screw home mechanism happen, depending on whether it's open or closed chained movement. But the knee itself, the knee joint itself, is externally rotating to help lock it into place. Now, unlocking the position. So here it says active knee flexion is the reverse. The fully extended knee must be unlocked through internal rotation by the gluteus muscle, which is true. It has to be internally rotated in both closed and open chain movement, though. So to release the screw home mechanism, the gluteus muscle must medially or internally rotate the tibia on a fixed open chain femur, or laterally externally rotate the femur on a fixed tibia, which would be a closed chain movement, which can be a little bit confusing because in the notes, if you go back to your chart, it says that it unlocks the knee by laterally rotating the femur on a fixed tibia. Well, that is correct, but it also will help to internally rotate the tibia on a fixed femur to help with that muscle too. So the gluteus muscle has more actions than just the one in the chart. It can it just more than just lateral externally rotating the femur on a fixed tibia. It also internally and medially rotates the tibia on a fixed femur, which would be open chain. It also has a slight potential for knee flexion as well because it's line of pull. So I just wanted to kind of get that out there. We'll talk about it more in class. I'm going to email you some notes that I have sent out in the past years because this is a confusing topic for some people. That kind of goes through all of these different things, and some of the things that doesn't seem right on the notes, but that are actually right. Just need to make sure that we're talking open or closed chain. Okay, we're going to keep going. So on the patellofemoral joint is this articulation between the femur and the patella. That's it kind of guides the tendon of the quadriceps onto the tibia. So it's primarily sliding motion that occurs simultaneously in front of the frontal and transverse plane. So we know that. So its main job, like I said before, is to increase the mechanical advantage of the quadriceps and protect the knee joint. So increasing mechanical advantage has something to do with usually increasing the IMA or decreasing the EMA. So we'll see what it does. So the patella tracks. It has a lot of different connections from ligaments as it goes across the knee. The opposing forces often counteract each other to help keep the patella in place and on the right position. If you break one or tear one, the patella can become dislocated and will no longer slide like it should when we have knee movement. So this is kind of how the patella works. And so when we are in full flexion, you can see the patella is kind of over here on this anterior part of the femur, and it's kind of anterior as far as it can go, basically. And as we begin to extend forward, we see that it starts sliding up the femur until it almost comes over the top of the ridge as it's in full extension. So that femur will migrate. As the patella migrates up the femur as the knee extends or flexes, and it helps keep everything in place. So this is what happens whenever this is how the patella increases their mechanical advantage, right? So we see here our axis of rotation, and then we want to measure our internal lumbar arm by the distance of the muscle attachment, basically, to the axis of rotation. So what does that do? That muscle attachment is basically here along that patella, and it has extended it by a good little amount. Without the patella, it is shortened. So now we have that muscle attachment closer to the axis of rotation, which decreases the internal lumbar arm and decreases our mechanical advantage. And this one we have increased internal lumbar arm and increased mechanical advantage. So that's how the patella helps us to extend our knee, really. And so without the patella, our quadriceps have to do more work to extend our knee. It still can do it, but it's a little bit harder. And so it really is giving us that mechanical advantage that we need to make extending the knee a little bit easier for our body. The Q angle is something that is this kind of the angle of pull that the body has on the patella, and you can see all the different muscles that are pulling in different directions. And the Q angle is like this overall or average angle of pull of the quadriceps pull on the patella. It has a lot to do with how the patella tracks in the knee. It's used to help if you have a patella misalignment or if there's an injury to one of the tendons. You can kind of tell by this angle of pull if there's an injury to one or the other. Normally about 13 to 18 degrees, and when the angle is larger than normal, the lateral pull on the patella is increased, which can help maybe dislocate it out of the way. And that's usually caused by weakness on the medial side, maybe, or an injury, something like that. Once again, there's not going to be a lot of questions in the test about Q angle. It's more you might hear be talked about in clinical spaces. So looking at knee movements, so we're looking at what's happening here. So we have EMA, external lumbar arm, of basically 0 when we're at full flexion, right? So this is the distance is nothing. As we start to extend, that EMA also goes out, so our EMA goes more. And at full extension, it's at its farthest point. We looked at that. We measure that EMA from basically the middle of the body segment. So the takeaway, as the joint angle decreases, external lumbar arm as the joint angle decreases, is we're looking at extension. Or if as we extend our knee, the EME also increases. So the external torque increases as well, and the amount of internal force needed to overcome external forces also increases. This should make sense, right? That as that external lumbar arm, that weight gets pushed out, we have to work hard to keep it in that position. Same thing kind of happens in squatting and closed chain, but it's kind of the opposite. So now we'll see here. So we have this 90 degrees of flexion. And we're getting close to that 90 degrees of flexion here, but where is our external lumbar arm? Well, it's actually pushed out and then pushed in, and when we're stand up straight, it's almost nothing again. So when we're in closed chain movement, as the knee angle decreases, the EMA decreases, so the external torque decreases, and the muscle has to do less to keep it in that position. So looking at closed versus open chain, you can see like these different angles there. When it's open chain, our EMA is 0 at flexion, and it's at its greatest in flexion when we are in closed chain. So we're having to, it's a little bit interesting to think about, but that is kind of how the closed chain, open chain can affect external lumbar arm, because what we're doing is moving the body versus moving just the leg. So this next part is a little bit more complicated, looks more complicated than it needs to be. But the basic idea is here is that as we squat deeper, we have more pressure put on our patellar tendons and forced through the patella, and so the tendons have more. These tendons, the quadriceps tendon and the patellar tendon, have a greater force pushed through them. So here, this kind of takeaway: deeper squat equals greater external torque on the knee, greater quad force needed to maintain squat. Also, the angle between the QT and the PT decreases. So that'd be here. So you can see before it was here, now it's here, which means the compressive force also increases. So you have more compressive force that's happening here because we have greater forces pushing this way, and our external arm has increased. And so we have so many things happening here. But the basic idea, which makes you probably don't even need to think about to explain, is that the deeper we squat, the more force we have put through the patella. There is this also thing that, and it's not as common now because polio is not as common, but in the past, whenever the things like polio, where the knee muscles became paralyzed or weak, we have this problem that would happen of geniorecurvatum, which is due to polio or an ankle fuse, whatever, and that makes it pushes the knee into hyperextension, so that we become the capsule or the ligaments in the back of the knee become overstretched, and they start pushing back. And so it also happens whenever our ankle is fused. It doesn't give any forward allowance of movement, and so it keeps that knee in that position. So we have this larger EMA of the knee, right? So the EMA has increased due to which increases the hyperextended deformity. So oftentimes, to fix that, we'll put these shoes on that puts them into kind of a fake flexion of the ankle, which pushes the tibia forward and then pushes the knee forward as well, which decreases the external arm and makes it so the hyperextension isn't as bad. But basically, just know from this that there's a thing called geniorecurvatum. It's hyperextension of the knee due to either paralyzation or overstretching of the posterior capsule. And if we can often change the angle of the ankle in order to help the position of the knee be in its right spot. These are all common problems that we see with the knee. There will not be specific questions on the test about these, but things you might see in notes. Often there's knee replacements, things like that, knee surgery. So I just wanted just things to know for the future. If you see them come up in clinical practice, you'll kind of be aware of what they are. So, okay, and then also you can kind of see this is how that medial collateral ligament is. Can be injured easily, right? So we have this running, and we have that medial collateral ligament is being overstretched, which can cause problems in the future. So once again, I'm not going to be doing a lot of test questions on this, but I just another ideas of what things that could happen clinically. So, anyways, I think the hardest things on there are just making sure you understand what the external internal rotation of the knee looks like, what's happening with open and closed chain, and just being aware of kind of what's happening with the tendons as movements are happening, and so kind of taking away from that, and also understanding the external arms and how they change with different positions of the knee. So we'll talk more about this in class, but just kind of look over these notes. Rewatch this if you need to. I'll send out that email that has some kind of notes, some of the notes I've sent out in the past about the lock screw home mechanism. But other than that, we'll plan on seeing you in class and hope you have a great rest of your day.